Hi guys, good afternoon, good evening, good evening. So, welcome to another series of Farre. This is going to be our GIT part 2, which we couldn't do it in the earlier part. So, in this, I'll be talking about all the previous exam questions on appendix, your rectum, as well as your anal canal. So, what are the important questions that they were asked? Again, in appendix, you cannot go to the exam without knowing about acute appendicitis, right? So, we had questions on acute appendicitis. So everything was asked in acute appendicitis, from its pathophysiology to that of causative agents, how do you diagnose it, management and everything. So talk about acute appendicitis was a question. Then there was a question on rectal cancer, diagnosis and management. Then there was a question on hemorrhoids and the that's your fistulas, the fistula in ano. So our objective is going to be to talk about all these four topics. It is going to be your acute appendicitis, your rectal cancers, your hemorrhoids, as well as your fistula in ano, right? So without wasting any further time, let's kickstart our discussion on acute appendicitis. So we'll be talking about all the important points in relevance to that of acute appendicitis. So we're talking about all the important points which are going to be in relevance with that of the acute appendicitis, right? Now, when you talk about acute appendicitis, it is classically described as the acute inflammation. It is an acute inflammation of appendix. It is going to be an acute inflammation of appendix, which is going to present to you as appendicitis. We'll see what are the reasons for the acute inflammation of that of the appendix, right? So when you talk about what are the causative or the pathophysiology, remember the pathophysiology of the acute appendicitis is going to be an inflammatory disorder, but here you will see the pathogen which are going to be present. It is going to be a combination of both aerobic as well as the anaerobic bacteria will be present. So when they talk about aerobic, remember usually the organism which is responsible for acute appendicitis, which is aerobic, is going to be E. coli, and anaerobic is going to be your bacteroids, right? Now, based upon how it is going to present, I can divide the pathophysiology into two categories. One is the obstructive, another one is a non-obstructive form. One is the obstructive form of the acute appendicitis, another one is the non-obstructive form. Another one is the non-obstructive form of the acute appendicitis. Now, it's a simple concept that if the appendicular lumen gets obstructed, the secretions are going to pull up in the appendix. Like in simple context, if you take this as the representation of the ascending colon, let's say this is the representation of the ascending colon that you have. This is where you have the cecum, and the junction between the cecum and the terminal ileum, you have the appendix, and this is your terminal ileum, right? You will notice that these bands which are present, which are called as the tinea coli, I hope everybody knows that three tinea coli which are present, all of them are going to be merging at the base. So one is going to be on the anterior surface, one on the posterior, another one is in lateral. All these tinea coli, when they merge together, they actually combine at the base of the appendix. They usually combine at the base of the appendix that you see. Now, usually the appendix can be present in different positions that you have. Remember the most common position, just for the sake of understanding, if I talk about the appendix, the most common position of the appendix is going to be retrocecal. It is behind the cecum that you'll see. It is going to be retrocecal. When you talk about the blood supply, you take this as a representation of the superior mesenteric artery. The superior mesenteric artery has three branches: the ileocolic artery, the middle colic artery, the right colic artery, and the middle colic artery. The three vessels which are present. This is what we call it as the ileocolic artery. This happens to be the right colic artery, and this happens to be the middle colic artery. We all know the middle colic artery. Will again divide them into the right branch of the middle colic artery and the left branch of the middle colic artery. So this is your right branch of the middle colic artery. This is your left branch of the middle colic artery. This is your left branch of a middle colic artery. The ileocolic artery, which is going to come across and supply to that of the terminal ileum. Along with that, it will also supply to a part of the cecum, but more importantly, the ileocolic artery will also supply. The ileocolic artery will also supply to that of the appendix. Now, what is interesting about the appendix is, if I just make it a little bit more dramatic about it, you will have a retrograde integration. Now, what do you mean by this is, you see this is the terminal ileal vessel. Now, from here, the terminal ileal vessel, you will see there is the branch that is going to come across, and it will insert the appendix at its tip. And this is what we call it as your appendicular artery. So the appendicular artery technically is a branch of the ileocolic artery, which is going to go and attach to the appendix, but it is not coming from the base. The supply is not coming from the base. The supply is coming from the tip of the appendix, and this happens to be the appendicular lumen. This is the appendicular lumen that is present. Now, we all know the blood supply in the entire bowel usually comes from the mesenteric border. So this happens to be the mesenteric border through which you will see the blood supply is going to come. So for the appendix, this becomes the mesenteric border. So it is the mesenteric border through which you will get the blood supply. So that was the mesenteric border of the appendix. That's the mesenteric border of the appendix, which is going to be present across here, right? Now, when we say the obstructive form, usually we have something called as a fecalith. Now, in a fecalith, you will see the stools are going to go and get stuck into the appendicular lumen. Now, if the stools are going to get stuck, what is going to happen? All the secretions which are going to be present will start pooling inside the appendix. Because of this, the lumen pressure of the appendix will increase, and that increase in luminal pressure will see when the pressure inside the lumen of the appendix will increase, it will not allow the blood to flow into the appendicular wall, hence causing hypoxia and ischemia, resulting in acute appendicitis, right? So this is how it is going to result in acute appendicitis. That's the basic pathophysiology. This is an obstructive form. Now, this obstruction can be because of various reasons. So what are the causes when you look at the obstructive form of the acute appendicitis? Now, the obstructive form of the acute appendicitis, number one, it is secondary to fecalith. This is the overall most common. It can be because of the parasites, example like the vermicularis. So it can be because of a parasite, that is a vermicularis. It can be because of a tumor, example like carcinoid tumors. It is the carcinoid tumors. It can be because of malignancy, that is your CA cecum. It can be because of Crohn's disease as well. The non-obstructive form is secondary to hypoxia or ischemic nature. It can be because of secondary to hypoxia or that of the ischemic nature, right? So these are the components that you're going to look in the form of the acute appendicitis, right? Now, what are the clinical features? How does a patient present to you of the acute appendicitis? So talk about the clinical features. Clinical features of acute appendicitis. Now, classically, when you talk about the acute appendicitis, we all know the appendix is present in the right iliac fossa. We all know the appendix is present in the right iliac fossa. So for the examiner, you can just draw a small representation of the abdomen, and this is the umbilicus and this is the midline that you have. So this is the midline that you have. So you can say this point that you have is your anterior superior iliac spine, and you can draw a line joining these two, right? And you can say there is something called as a McBurney's point. The McBurney's point is going to present from the medial 2/3 and the lateral 1/3. This corresponds. This is what we call it as the McBurney's point. This McBurney's point corresponds to the base of the appendix. This corresponds to the base of the appendix. So this is basically fixed. Now why it is important is this is the site for maximum tenderness. This is the site for maximum tenderness. So the McBurney's point corresponds to the base of the appendix, and this is the most common site or the maximum site of the tenderness. How do you know it is from anterior superior iliac spine to the umbilicus? You draw a line, and then between the the border between the medial 2/3 and the lateral 1/3, this junction is what we call it as the McBurney's point. It corresponds to the base of the appendix. This corresponds to that of the base of the appendix, right? Now, what are the clinical features that you're going to experience? Now, patient will present to you. See, appendicitis is an inflammation of ruber-callus dollar tumor. So these are the presenting features that you will see. So patient is going to have pain in the right iliac fossa. Patient will have pain in the right iliac fossa. It will be associated with fever, and patient will also have anorexia. So there is pain, fever, and anorexia is the component that you will present, that you will see in the patient of acute appendicitis. Few patients of acute appendicitis can also present to you with diarrhea, but that is when the pelvic in position. If the appendix is pelvic in position, if it is pelvic in position, due to irritation of the bowel, it can also result in diarrhea. It can also result in diarrhea. So when a patient presents to you with these features, I would like to examine. So on examination, what are the findings that you're going to see? On examination, the first finding, there will be right iliac fossa tenderness. Along with that, there will be right iliac fossa rebound tenderness. So there is right iliac fossa tenderness is noticed. Then there is right iliac fossa rebound tenderness will be noticed. There will be rebound tenderness will be noticed. See, in the clinical features, now along with anorexia, also add these patients will also have nausea as well as vomiting. That is because of the ileus secondary to appendicitis. Okay? So you have the right iliac fossa tenderness, there is rebound tenderness, patient won't let you touch, so there is presence of guarding. Patient won't let you touch the abdomen, there will be presence of guarding as well. Now, because obviously it's an inflammatory disorder, there is pain, and that pain will also cause tachycardia, so will be increased heart rate. So patient is also going to have tachycardia. Then that can be secondary to fever, pain, and all that is taken into consideration. Now, there are certain clinical signs that you should mention in your exam. Now, what are the clinical signs that you can see? So I'll just quickly mention the clinical signs in acute appendicitis. So we'll talk about the clinical signs. Now, the clinical signs which are associated in acute appendicitis, number one, you have the Rovsing sign. Now, what is this Rovsing sign? Rovsing sign, when you press in the left iliac fossa, because the content is being shifted into right side, obviously pressure in the right iliac fossa will increase, hence causing pain. So pressing on the left iliac fossa causes increase in pain of the right iliac fossa, is what we call it as the Rovsing sign. Second one that you have is what we call it as the psoas sign. It is when it is going to be touching the psoas muscle, right? Psoas sign is positive when the appendix is retrocecal in position. When it is retrocecal in position, it is going to rub onto the psoas muscle, right? So this is going to be present as pain on hyperextension of the hip. So presence of pain on hyperextension. Pain on hyperextension of the hip is what we call it as the psoas sign positive, right? Next one you have is the obturator sign. Next one that you have is the obturator sign. Now again, it is if the appendix is pelvic in position. This is for appendix which is pelvic in position. Now if the appendix is pelvic in position, the pain on the right iliac fossa will increase on internal rotation of the hip. So here I can say the pain increases in right iliac fossa on the internal rotation of hip. On the internal rotation of the hip. That is your obturator sign. Another one that you will see is your pointing sign. Pointing sign, here the patient is going to use the index finger to point the maximum site of tenderness which corresponds to that of the McBurney's point. So patient uses index finger to localize maximum site of tenderness. Maximum site of tenderness, that is your pointing sign, which corresponds to the McBurney's point. Which corresponds to that of the McBurney's point, right? The last one that is going to be there is going to be your Bestedy sign. Bestedy sign, if you inflate the rectum or you do a per-rectal examination, so on digital rectal examination, there will be pain increase in right iliac fossa. The pain increase in right iliac fossa, that is a Bestedy sign. So these are the clinical signs on the acute appendicitis that you should be aware of. Now, obviously, when the patient comes to you with appendicitis, you would like to evaluate in terms of investigation. In terms of investigation, you have to get the CBC, that is complete blood test. You have to get the USG of the abdomen and pelvis. And to confirm, you can go ahead with CECT abdomen. But more importantly, clinically, we have a scoring which is called as the Alvarado scoring system for acute appendicitis. So looking at the Alvarado, it is the Alvarado scoring for acute appendicitis. Now, the mnemonic to remember the components of the Alvarado scoring system is what we call it as the mantle. So we'll talk about mantrals as the mnemonic to remember all the important points about the Alvarado scoring system. Now, according to the Alvarado scoring system, the first set that you will see are considered to be as symptoms. Now, the symptoms that you will see will be presenting with MANN, that is your mantral command. Now, M stands for migratory right iliac fossa pain. It is going to be a migratory right iliac fossa pain. That means when the patient will complain, initially patient will say there is a diffuse abdominal pain, and later on it localized to the right iliac fossa, there is a migratory right iliac fossa pain is noticed. Anorexia is one of the most consistent finding in acute appendicitis. Along with that, there will be nausea and vomiting. Along with that, there'll be nausea and vomiting. Then the second one that you will see is going to be signs. So what are the signs that you will see? That is mantral, that is T, R, E are the signs that you will see in mantral. Now what are the C? T stands for right iliac fossa tenderness. This is right iliac fossa tenderness. R stands for rebound tenderness. R stands for rebound tenderness. And E stands for, that is fever, that is elevated temperature. This is elevated temperature. This is an elevated temperature. E stands for elevated temperature. So done with the symptoms, done with the sign, and then you have the lab values. So MAN is then TRE, so mantral is then LS is rectal. So L and S. Now L stands for leukocytosis. It is leukocytosis, that is elevated WBC counter, and S stands for shift to left. It is a shift to left. Now all the scoring system or the components are given to give you a proper scoring for all of them. So let's talk about what is the score that they are going to get out of it. So the score that is going to be given for migratory, see, for all symptoms you can remember, I'll give you an easy way to remember. Symptoms is going to be 1. So migrate, that is pain, anorexia, nausea will have a score of 1, 1, 1. Signs, 1 will have a score of 2 and the rest is going to have a score of 3. So you'll see the tenderness is going to be your score of 2 and the rest is going to be a score of 1. Same here. In your lab, leukocytosis will have a score of 2, shift in left is going to be 1. So when look at the total score is going to be of 10. So when you look at the mantrals, the total score, when you look at the total score for mantrals is going to be 10. And 10 is confirmatory for acute appendicitis, right? So 10 is going to be confirmatory for your acute appendicitis, right? So normally we say at what component would you suspect it, when would you confirm it and all that. Remember, confirmation of acute appendicitis, confirm acute appendicitis, if a score is more than or equal to 9. Highly suggestive or highly likely of acute appendicitis if a score is more than or equal to 7 but less than 9. When we do a CT, so CECT abdomen is to be considered when you are in doubt. Now CECT abdomen, when a score is less than or equal to 6, to confirm that of acute appendicitis, you have to go ahead with CECT abdomen. You have to go ahead with CECT abdomen, right? Now, just to summarize the whole component that we have learned, what are the other differential diagnoses that you can look in the context of acute appendicitis, right? So, differential diagnosis. So differential diagnosis for acute appendicitis. For acute appendicitis. So the differential diagnosis for acute appendicitis, especially in children, it is going to be the Meckel's diverticulum. It is going to be the Meckel's diverticulum. It can be seen in secondary to ureteric colic. It can be secondary to ureteric colic, especially if there's a torsion testis on the right side. So right testicular torsion. Right testicular torsion. It can also be mimicked by pancreatitis. where you have diffuse abdominal pain. In females, it can be secondary to PID, that is a pelvic inflammatory disease, secondary to ectopic pregnancy. So especially in fertile females, always get a UPT done before going for any further investigation, that is a urine pregnancy test, to rule out if the patient is pregnant or not. So ectopic pregnancies are another important component. Torsion or ruptured ovaries. Torsion or ruptured ovaries, right? And the last one is endometriosis. So these are the differential diagnosis of your acute appendicitis that you should mention when you're going with the investigatory property. Okay? So basically the cross-sectional imaging is going to rule out all these components, and then you will confirm that the patient is having an acute appendicitis, right? Now, how do you manage? The management of the acute appendicitis depends upon that what is the presentation. Is it only an acute appendicitis? Is there a perforated appendix, or is there an appendicular mass? So the management depends. Are you dealing with acute appendicitis? Is there a perforated appendix? Or if there is an appendicular mass? If there is an appendicular mass. Now, if the patient presents to you with simple acute appendicitis, then the management is straightforward. It has to be surgery, and surgery is going to be appendicectomy. It is going to be appendicectomy. Now, when you talk about the appendicectomy, what are the common incisions that you can talk about? So we have two options. You can go ahead with open appendicectomy as well as your laparoscopic appendicectomy. So either you can go ahead with open appendicectomy, or you can go ahead with laparoscopic appendicectomy. Preferred one as of today is going to be a laparoscopic appendicectomy. Now, in an open appendicectomy, what are the incisions that you have? So we have the grid iron incision. So three standard incisions. Number one is going to be the grid iron incision. Then you have the Rutherford, the Rutherford-Morrison's incision. And the cosmetically acceptable is your Lanz incision. So three incision, grid iron, Rutherford, as well as your Lanz incision. Now, what is interesting about each one of them is the grid iron is a muscle splitting incision. It is your muscle splitting incision. Rutherford-Morrison is your muscle cutting incision. And Lanz is a cosmetic incision. Lanz is also muscle splitting, but it is more cosmetic, right? So where would you put the incision? Now, if you take this as the representation of the abdominal wall, this is the appendix. Now, as we know, the McBurney's point is going to lie somewhere here. That is the junction between the lateral 2/3 and the medial, medial 2/3 and the lateral 1/3. So when you talk about the McBurney's point, so if you join these two lines, this is going to be the medial 2/3 and the lateral 1/3. You will see the McBurney's point, right? Now the grid iron incision is going to be like this. So this is the incision, which is called as a grid iron incision, which is a muscle splitting. Now, what is a Rutherford-Morrison's incision? It is nothing spectacular. If you extend the grid iron incision laterally to gain more access, right? Same grid iron incision, if I extend my incision more laterally and cutting the muscle to gain more access, it will become Rutherford-Morrison's. Whereas when you talk about the Lanz incision, if you draw, this is your mid-clavicular line, right? So usually it is going to cross your McBurney's point. At this point, if you give a transverse incision, A transverse incision at this point is your Lanz incision. As simple as that, right? So 3 incisions that we spoke across here. Number 1 is your grid iron incision. Number 1 is your grid iron incision, which is here. Then you have the Rutherford, which is here. And then you have the Lanz incision, which is here. Right? All these 3 are the incisions that you are supposed to keep it for your acute appendicitis. For your acute appendicitis. Clear? Now, if you have a patient who is presented with your perforated appendix. For a perforated appendix, patient would present to you with signs and symptoms. The signs and symptoms of peritonitis. There be signs and symptoms of peritonitis. Right? Now, in signs and symptoms of peritonitis, you can see there is presence of abdomen, there is presence of guarding. There will be presence of rigidity in the abdominal wall. There will be diffuse abdominal pain. There will be this diffuse abdominal pain. Right? For these patients, you have to take the patient for exploratory. Take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy. Now, if there is an abscess, if there is an appendicular abscess, then I am going to place the abdominal drain and exit. If there is presence of gangrene, if the gangrene is involving the base of the appendix, or if it is involving the tip of the appendix. If it is involving the base of the appendix, I will see whether it is involving the cecal wall or not. We'll see whether the cecal wall is involved or if the cecum wall is spared. If the cecum wall is involved, then we have to go ahead with right hemicolectomy. If the cecal wall is not involved, then you can do an appendicectomy. And you have to bury the appendicular stump. Bury the appendicular stump with purse string suture. If it is just involving the tip, then perform an appendicectomy. If it is just the tip, then you have to put appendicectomy. So this is if it is going to be in terms of complication. The last one that you get is going to be your appendicular mass. Now, if a patient presents to you with appendicular mass, then you have to follow something called as the Ochsner-Scherin's regime. For appendicular mass, we are going to follow something called as the Ochsner-Scherin regime. Your Ochsner-Scherin regime. Now, what does this Ochsner-Scherin regime basically tells you? That first mark, you have to measure, no? So, mark the appendicular mass. See the size and just mark it. Second, start the patient, let's keep the patient on Nelparol, start the patient on IV fluids, give IV analgesia, and then give IV antibiotics. Keep the patient Nirpa oral, start the patient on IV fluids, give IV analgesia as well as IV antibiotics, and monitor vitals. Usually they respond. Once they respond, discharge the patient. Ask the patient to come back after 4 to 6 weeks for interval appendicectomy. For an interval appendicectomy, right? So this is how you have to give your answer for your acute appendicitis management. Now, if you put this table, no, the management table, your examiner is going to be super impressed, because you know you have covered everything from a simple appendix to a complicated appendicitis to that of an appendicular mass. You know the management of all three of the components. So whenever asked, you can put your answer in that precise manner, right? I hope everybody is clear. Clear? Okay. So that is the first 10 mark question that we have covered. That is your acute appendicitis. That is done. Okay. Chalo, let's go down to rectal cancer. So the next question that we'll be covering is going to be about the rectal cancer. Now, in fact, when you talk about the entire GI malignancies in terms of colorectum, you will see that around 38% of the total malignancies that are going to be present are going to be arising from the rectum itself, right? So rectum is overall the most common site for the large bowel malignancies. Okay? So when you talk about any cancers, you should first know the risk factors. So I'll be addressing the risk factors for the rectal cancer. So we talk about the risk factors associated with that of the rectal cancer. Now, in the risk factors, the most important risk factor is going to be high fat intake. High fat intake with low fiber diet. High fat intake with low fiber diet. Then you have the genetic components. The genetic components are example like familial adenomatous polyposis, Gardner syndrome, Turcot syndrome, Lynch syndrome. Your Lynch is nothing but HNPCs, that is hereditary non-polyposis colorectal cancer. So FOP, Gardner syndrome, Turcot syndrome, Lynch syndrome are the genetic components that you have to remember. It is also associated with inflammatory bowel disease. Also associated with the inflammatory bowel disease. Earlier we used to say that Crohn's disease has a higher incidence when compared to ulcerative colitis. Now ulcerative colitis and the Crohn's disease have the equal incidence. It has got an equal incidence of development of the rectal cancer. When you talk about in the entire context, I can say ulcerative colitis is slightly higher, because in Crohn's usually we see rectal sparing. So whereas ulcerative colitis, rectum is the most common site. So if you ever want to pick it up as one single answer, then I would say ulcerative colitis is slightly more common when compared to Crohn's disease. Otherwise, they both exist in the same component. Okay? So this is in the context of inflammatory bowel disease. Then it is also associated with polyps. Remember, the maximum risk is associated with the adenomatous polyps. It is associated with the adenomatous polyps and the history of pelvic radiation. And the history of pelvic radiation. And the history of the pelvic radiation. Now, when you talk about the rectal cancers, so let's talk about the clinical presentation. So talk about the clinical features of the rectal cancer. Now, to understand the clinical features, just for the sake of understanding, if you take this as a representation of the ascending colon, this is the ascending colon, this happens to be the hepatic flexure, this happens to be the transverse colon, This is the splenic flexure. This happens to be the descending colon. This is the sigmoid colon. And from here you will see your rectum is going to start. This is the rectum and this happens to be the anal canal, right? So in the sake of understanding, rectum comprises on the left side. So when you talk about the colon cancers, the left-sided components are going to be quite different. So this is where we say the junction between the sigmoid colon and the rectum, and this is the junction where you have the rectum and the anorectal junction, right? So this is your sigmoid and the rectal junction. This is your anal canal and the rectal. This is your anorectal junction, right? So this is what we call it as the anorectal junction. So usually when the tumor is going to arise, it is going to arise in the rectum somewhere across here, right? Now what are the clinical features? Now as it starts to develop, and that too on the, if you look at the colon, this is the right side of the colon, this is left. So it's going to be in the left-sided features, right? Now how would they present to you? Now most of these tumors, they are vascular, right? So because they are vascular, they're going to bleed and they're also going to cause obstruction. So the first thing the patient will experience in the rectal cancers, the patient will have constipation. There's a constipation relieved with diarrhea. So what happens is all that stools which are going to be present, they will come and they get blocked here because there is a mass or growth here. So patient will not be able to defecate. So hence there is a constipated feeling. Because it's a tumor, the tumor has the ability to secrete. So there's a lot of secretions that are going to be present from the tumor, and that secretion will be liquidative. And that in general will liquidate the entire component of the stools. And now the patient will present to you with diarrhea. So there is obstruction due to the mass that results in constipation, but there is a fluid that is going to secrete, or a lot of secretions from the tumor will liquidate these stools, and the patient will pass a liquid stools. Now this is usually on the early morning and is rich in all the secretions. So there will be presence of an early morning spurious diarrhea. And obviously because of this, the patient will have multiple defecations, again different timings. So there is alteration in bowel habits. Patient also have a lower GI bleed, and here it will be more of hematochezia. Now hematochezia is a fresh blood in stools when compared to melena, which is old blood in stools, right? So your hematochezia indicates it's probably a rectal or an anal canal disorder. Your melena indicates the distal part, that is from the sigmoid colon or the ascending or descending colon. So there you have the hematochezia as well as melena. They'll also be associated with significant weight loss. Remember the most common route of spread. For the entire GI or the colorectal malignancies is hematogenous, that is blood, and the most common site for metastasis. The most common site for secondaries or metastasis is usually liver, because the entire GI system is drained by your portal system, and that portal system goes and opens into the liver. So hence patient is going to have liver secondaries. Now obviously patient has presented lower GI bleed. So what are the investigations that we are going to conduct? Now in terms of investigation, the first one is going to be a DRE, that is your digital rectal examination. That is going to be a DRE, that is your digital rectal examination. Now after the digital rectal examination, you might feel there is something. So go ahead with colonoscopy. Now, obviously, when you see a mass which is present in colonoscopy, you have to get a biopsy done. You'll also get a CECT of the abdomen to look for the extent of the tumor, and to confirm, once it is confirmed as malignancy, to know the staging, you have to go ahead with PET-CT. The PET-CT is for the staging of the cancer. Now, there is a staging that we all should be aware of, that is called as the Duke's staging. Now, according to the Duke's staging, there are different components that you should be aware of, right? So, when you say Duke's staging of the colorectal cancer, they are organized in an alphabetical order, right? So, we have Duke stage A, which is tumor limited to mucosa and submucosa. Tumor limited to mucosa and submucosa. B is tumor between submucosa and serosa. That's a B1. Then you have B2 is tumor beyond serosa. It is a tumor beyond serosa. Then C1 is B1 with involvement of regional lymph nodes. C2 is B2 with involvement of regional lymph nodes. D stands for distant metastasis. D stands for distant metastasis. Clear? Now, once you have concluded the Duke staging, let's talk about the management of the rectal cancer. Now, in terms of management of the rectal cancer, we need to follow something called as the margin of resection. Now, what is the margin of resection that you will follow in rectal cancers? So, there are two margins that you have to obey. One is your proximal margin, another one is your distal margin. So, one, there is a proximal margin, another one is a distal margin. The proximal margin is going to be 5 centimeters and a distal margin is going to be 2 centimeters from the tumor to achieve an adequate resection. Now, what do you mean by this? So, for this, you have to depict that this is the sigmoid colon. Let's say this happens to be the sigmoid colon. This happens to be the tinea coli, to tell you that this is where the sigmoid colon ends and this is where the rectum is going to start. So, when you take this as a representation of rectum, this happens to be your anal canal, right? Now, if you look at the whole orientation, on the posterior aspect, you have the vertebra that is present. So, I'm just depicting this as the vertebra. On the anterior aspect, you have the pubic bone. So, I'll just say this is your pubic symphysis, right? There is a muscle that is present here, which is like a sling muscle attached on both ends, and this is what we call it as the puborectalis. Now, there's a muscle that is present at the anorectal junction, and the muscle that is present at the anorectal junction is what we call it as puborectalis. It's an extension of the levator ani muscle, which is actually a pelvic floor. So, why this is important? This muscle actually maintains the continence, right? So, this anorectal angle, no, that is, so if you have to imagine it, imagine that this muscle pulls this anorectal junction towards the pelvis. So, obviously, this is going to get compressed. Now, because it remains compressed, it gives the strength to the anal canal to hold these stools and not allow it to pass. So, this is one of the most important, or the most, I would say, overall the most component mechanism to maintain the continence, right? But this, if I had to explain tinea coli, then it's going to get difficult. It's a band of tissue that is present over the large bowel, which divides them into these compartments which are called as hastrations. So, this is what your tinea coli is. Okay. Chalo. Now, you will see a lot of fat is going to be present along the rectum. There's a lot of fat that is present along the rectum. Now, this fat is very important from a surgical standpoint, because all the lymph nodes which are present, no, all the lymph nodes are present or embedded inside this fat, right? So the lymphatic drainage of the rectum is in this perirectal fat that is going to be present. Now, why this becomes very important for us is, you need to understand that the whole concept of the oncology depends upon the adequate resection that you can bring across. Okay? You will see there is a peritoneal reflection that is going to be covering the sigmoid colon, and this reflection is what we call it as the serosa. So serosa is actually a fancy word. Serosa is nothing but the parietal peritoneum. It is nothing but your visceral peritoneum, right? This is the serosal surface, which is called as the visceral peritoneum. You will now notice that this is going to only cover the upper 1/3 of the rectum. From there, there is no peritoneal cover, there is no serosa. So rectum per se does not have any serosa, right? This arches out, there's a bladder here, and obviously in female there will be uterus and all, but this is where the arch is there, nothing else is going to be present. Okay? 1 second. Right. In front of the vertebra, there is this prevertebral fascia, right? So you see this, which we have seen here. It is your prevertebral fascia. This is your prevertebral fascia. On the rectum, you will see there is this layer that is present. We have a layer over the rectum, and that is called as the investing fascia of the rectum. So you'll see this is the layer that is present, and this is what we call it as the investing fascia of the rectum. There is this investing fascia. There is the investing fascia of rectum, which is here, right? Now there is a fascia that is connecting the prevertebral fascia and the investing fascia of the rectum, and this fascia is what we call it as. There's a fascia that is going to cover these two. That is prevertebral fascia connecting to that the investing fascia of the rectum, and this is what we call it as the Valdeas fascia, also called as the rectosacral fascia. This rectosacral fascia is what we called as the Valdeas fascia. On anteriorly, you will see that this same thickening is going to cover the prostate as well as the rectum. It divides the prostate anteriorly and the bladder there, and this is what we call as the Denon-Vellers fascia. It is your Denon-Vellers fascia. This is your Denon-Vellers fascia. Now, why it is important is, when you are removing the rectum, you have to remove with its fat. Now, when you remove with its fat, the concept is what we call it as TME, that is total mesorectal excision. If you don't remove the mesorectum, that mesorectum is nothing but the fatty component, you have done an inadequate dissection. The recurrence of the malignancy will occur. Now, if I give you an easier version of the management protocol, let's say this is where the rectum is going to start, and let's say this is where the anal canal is going to end, and this is your anorectal junction, and this is your perianal skin. Normally we say that if this is the tumor that is present, we have to obey the margin of resection. So we have the proximal margin. This is what we call as the proximal margin. The proximal margin of the resection. This proximal margin, we never have a problem with proximal margin because it is quite adequate. The problem always lies with the distal margin, because the minimum distal margin that you should have, the minimum distal margin that you should have in the rectal cancers is going to be 2 centimeters. So once you have resected it, I'm going to measure from the lower margin, that is from the distal margin's lower end, to that of the anal verge. Now, anal verge is a junction between the anal mucosa and the skin. This decides. So this is the distance between the lower margin, and anal verge. And the anal verge, we will measure this distance. Now, if this distance is more than 5 centimeters, then you can go ahead with resection and anastomosis. You can go ahead with resection and anastomosis. But if this distance is less than 5 centimeters, then we will prefer something called as APR, that is abdominoperineal resection. And APR is your abdominoperineal resection. Now, APR and abdominoperineal resection is basically a surgery where you're giving a patient with permanent colostomy. There is this permanent colostomy that you're creating. So here the anal opening will be closed because you've removed the entire anal canal. There will be descending colon will be opened onto the left side of the abdomen, remaining as colostomy for the rest of his life. And this is what we call as APR. You'll also give the chemotherapy to these patients, and the chemo regime that we follow is of FOLFOX, or you can also give the Folfovir. Now in FOLFOX, FOL stands for folinic acid. Another F stands for 5-fluorouracil, and OX stands for oxaliplatin. Another one here also, FOL stands for folinic acid. Another F stands for 5-fluorouracil, and then you have the irinotecan. Then you have the irinotecan, right? So these are the chemo regimes that you have to follow with rectal cancer. So this is how you will manage your patients of rectal carcinoma. Clear? So finished our second 10 marks question, that is your rectal cancers. So talking about the hemorrhoids and the fistula, I'll cover both of them in a single subset. So talk about hemorrhoids. So the next answer that we're talking about is going to be about the hemorrhoids. Now, hemorrhoids are classically defined as dilated. They are dilated, distended, submucosal anal cushions. So these are nothing but the veins which are draining the submucosal segment. So these are dilated, distended submucosal anal cushions is what we call it as the hemorrhoids, right? Now, when you talk about the hemorrhoids, what are the risk factors? One of the major risk factors for the hemorrhoids are considered to be constipation. It is secondary to constipation, passing hard stools. The secondary to passing hard stools. It can also be seen secondary to portal hypertension. It is seen in connective tissue disorders. It is seen in the connective tissue disorder. So there is this constipation, passing hard stools, portal hypertension, connective tissue disorders, secondary to pregnancy. And rectal malignancy. These are the usual risk factors for the development of hemorrhoids. Now, we classify the hemorrhoids based upon their presentation. So we simply go ahead with hemorrhoids classification. So when we talk about the hemorrhoids classification, it is based upon their location and based upon their origin. So one subset of hemorrhoids, we classify them into internal and the external hemorrhoids. So we have the internal hemorrhoids and then you have the external hemorrhoids. One we have the internal hemorrhoids, another one we have the external hemorrhoids. Another subset of classification that you can see, it will be seen as primary hemorrhoids and the secondary hemorrhoids. So one you have the primary hemorrhoids, another one is your secondary hemorrhoids. So what is the internal external hemorrhoids? It's quite simple. You take this as the representation of the anal canal, and this is your dentate line that is present, and let's say this is the rectum, which is going to be above this. So this is the rectum, and then it continues into anal canal, and this is your anal verge, and this happens to be your anal mucosa. Any hemorrhoid that is present above the dentate line is what we call as internal. Below the dentate line is what we call as the external hemorrhoids. So these are considered to be as internal hemorrhoids, and these are considered to be as external hemorrhoids. So external hemorrhoids are below dentate line. They are present below the dentate line. Internal hemorrhoids are the hemorrhoids that are present above the dentate line. So internal hemorrhoids are present above the dentate line, external hemorrhoids are present below the dentate line. Then comes the primary and the secondary hemorrhoids based upon their venous drainage. So you take the cross section of the rectum. This is the rectal mucosa. The cross section of the rectum, and this happens to be the rectal mucosa. Now when you point it as a clock, you will notice that this is 12 o'clock, this is 6 o'clock, this is 3 o'clock, this is 9 o'clock. So this is 12, 3, 6 and 9. Same here, 12, 3, 6 and 9. 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Now if the hemorrhoid arises from 3 o'clock, if it is arising from a 7 o'clock, or it is arising from 11 o'clock, it is called as a primary hemorrhoid. Anywhere else than that, if it is arising from 12 or from here, if it is arising from a 6 o'clock or a 9 o'clock, it is considered to be a secondary hemorrhoids. So hemorrhoids arising, if it arises from 3, 7 or 11 o'clock, that is primary hemorrhoids. If it arises anywhere else, if it arises anywhere else than 3, 7 and 11. If it arises anywhere else than 3, 7, 11, it is called as your secondary hemorrhoids. So this is the classification of hemorrhoids between internal and external, primary as well as secondary hemorrhoids, right? Usually when we talk about the clinical presentation of the hemorrhoids, the clinical features of the hemorrhoids is going to present to us bleeding per rectum. They usually presents to you with bleeding per rectum. That's a usual presentation. Now because they're presented with bleeding per rectum, I would like to investigate in terms of investigation. Obviously I will go ahead with digital rectal examination, but more importantly I will go ahead with proctoscopy. Now based upon the proctoscopy, we have different grades of hemorrhoids that we have. So the grades of hemorrhoid is on the basis of bleeding that is going to be present, and is the hemorrhoid protruding or not, that is protrusion. In grade 1 hemorrhoid, there is presence of bleeding, there is no protrusion of the hemorrhoid. Grade 2 hemorrhoids, they will see the presence of bleeding, the presence of protrusion, but it spontaneously reduces. It spontaneously reduces. Then you have grade 3 where there is presence of bleeding, presence of protrusion, but here it is manually reduced. Here it is manually reduced. Then it is grade 4 hemorrhoids where there is presence of bleeding, protrusion is present, but this time it cannot be reduced manually, it is prolapsed. This is usually prolapsed, right? So these are the grades of hemorrhoids that you should be aware of. How would you like to manage? In terms of management of hemorrhoids, it is a grade wise management that you have. So grade 1, grade 2, grade 3 and grade 4. So for grade 1 hemorrhoids, it is going to be a conservative management. Now in the conservative management, number 1, we'll try to give the patient a soft diet. Make these stools softer, so I'll give laxatives. I'll ask the patient to take sitz bath and adequate hydration. So we'll give soft diet, laxatives, sitz bath, adequate hydration and increased fiber diet. Grade 2 hemorrhoids, we can try conservative. We can try a conservative management. If this fails, then you can go ahead with banding or you can go ahead with sclerotherapy. Grade 3, we usually go ahead directly with banding. If it fails, then you go with surgery. Grade 4, we will prefer surgery alone. So when you talk about the surgery, what are the surgeries that you have? Number 1, you can have the Milligan-Morgan surgery. Then you have the Ferguson's surgery. The difference is Milligan-Morgan, you excise the hemorrhoid and leave the mucosal segment open. Whereas in Ferguson's, you suture it back. The third one that you have, that is after Milligan-Morgan, when you've done the Ferguson surgery, third one that you have, your stapler hemorrhoidopexy. It is usual circular stapler. So Milligan-Morgan surgery, Ferguson surgery and stapler hemorrhoidopexy can be performed in your hemorrhoidectomy, right? So these are with respect to management of the hemorrhoids. Okay. So we finished our third question as well, and that is going to be our hemorrhoids. The last question that you should be knowing is your fistula in ano. So let's go to fistula in ano. So talk about the fistula in ano. The fistula in ano is described as an abnormal communication. It is an abnormal communication between anal mucosa and perianal skin. So it's an abnormal communication between the anal mucosa and the perianal skin is what we call it as the fistula in ano, right? Now let's understand what is the underlying cause. What is the underlying cause for the fistula in ano? The underlying cause for the fistula in ano can be divided into primary cause and the secondary cause. So look at the primary cause and we look at the secondary cause. So when we say the primary cause, there are two important primary causes. Number 1, if there is a spontaneous rupture of perianal abscess. The spontaneous rupture of perianal abscess, or if there is an inadequate drainage of perianal abscess. One, there is a spontaneous rupture of the perianal abscess. Second, there is an inadequate drainage. Is there an inadequate drainage of the perianal abscess? So can you explain what is fissure? But a fissure is actually a longitudinal ulcer at the anal verge due to passing hard stools, or it is because of repeated strenuous frictional irritation of the anal mucosa. Now, we talk about the secondary causes. The secondary causes for the perianal fistula or the fistula in ano, it can be secondary to Crohn's disease. It can be secondary to tuberculosis. It can be secondary to radiation proctitis. Crohn's disease, tuberculosis, radiation. It can also be secondary to actinomycosis. So Crohn's, TB, radiation, and actinomycosis are the secondary causes for fistula in ano. Okay. Now, based upon where the opening starts and where does it end, we have a classification for the fistula in ano, and that is what we call it as the Parkes classification. We have the Parkes classification of the fistula in ano. Now, according to the Parkes classification, let's understand this. Now, if you take this as the representation of the rectum, and let's say this is the anal canal that we have, right? This is the perianal skin, which is going to be present here. So just representing it here. Now, there are two sphincters which are going to be present. I hope everybody knows it. The first one is what we call it as the internal anal sphincter. The internal anal sphincter is actually an extension of the circular muscles. So when the circular muscles of the anal canal, they hypertrophize and they form the internal anal sphincter. So the internal anal sphincter is actually a smooth muscle. Then you see on the outer surface, you have the external anal sphincter. So this is your external anal sphincter. Now the external anal sphincter is actually a continuation of your pelvic floor muscles. So it's a skeletal in origin. So this is your external anal sphincter. So you see this is the external. So this is your external anal sphincter. So this is the integration of your internal anal sphincter. And this happens to be the integration of your external anal sphincter, right? For the sake of understanding, I'm just going to mark it down. So this is your internal anal sphincter, which is here. This is your external anal sphincter. At this junction, we know there is a muscle that is present, and that muscle is going to be your puborectalis. This muscle that is present is your puborectalis, right? Now, where does it open? Where does it end? All these is important components. So this is your internal anal sphincter that we have, and the external anal sphincter. Now you'll notice if the inner opening is in the, see, there has to be two openings to call it as a fistula. One has to be inside the anal mucosa, one has to be on the skin. So if there is one opening here, another opening here, and you see the tract is going to be in this manner. So you can see it is piercing the internal anal sphincter, traveling between the internal and the external anal sphincter, opening into your cutaneous. This is your intersphincteric variety. Another one, there's internal opening here, the external opening here. You can see the tract piercing both the internal and the external anal sphincter. This is what we call as transsphincteric. The internal opening is here, the external opening is here. The tract which is going to be present, it is going to actually travel. The tract travels above the puborectalis and then opens. This is called as suprasphincteric. If the opening is in the rectum, bypassing the entire sphincter apparatus and then opens on here, this is what we call it as extrasphincteric, right? So according to the Parkes classification, the 4 varieties of fistula in ano that you see. Now the first variety that we have mentioned here is what we call it as the intersphincteric variety. It is the intersphincteric type. The type 2, it is piercing both. It is your transsphincteric variety. It is your transsphincteric variety. Type 3 is going to be suprasphincteric. It is your suprasphincteric type. And your type 4, okay, the type 4 is what we call it as extrasphincteric type. So type 1 is the first one is intersphincteric, then you have the transsphincteric, then you have the suprasphincteric, and then you have the extrasphincteric variety. So all these are considered to be as the different forms of the fistula in ano. It is your fistula in ano, right? Now, how does the patient present to you? We talk about the clinical features. Now, clinical features of the fistula in ano. The first thing that the patient usually complains or will say is there is a foul smelling. There's a foul smelling perianal discharge. Now that foul smelling perianal discharge is nothing but stools that have traveled from the fistulous tract and getting accumulated. There is presence of cutaneous. There's presence of the cutaneous ulceration. There is presence of cutaneous ulceration around anal verge. There's a cutaneous ulceration around the anal verge that is present. Along with the cutaneous ulceration, you'll also need, there'll be fecal soiling. There'll be fecal soiling of undergarments. So there'll be a foul smelling perianal discharge will be present. There'll be a cutaneous ulceration around the anal verge is noticed. There'll be fecal soiling of the clothes are addressed. There is fecal soiling. There'll be fecal soiling of the undergarments is noticed. Along with that, patient will give you a history, probable history of perianal abscess. Now, whenever you have a presentation like this, the investigation that you would do, number 1, we will do a digital rectal examination. Number 2, I'll do a proctoscopy to see any opening is visible. Then I would like to go ahead with the MR fistulogram. For complex varieties, you can also plan for endoanal ultrasound. So digital rectal examination, proctoscopy, MR fistulogram, and the endoanal ultrasound is what you have to do for your fistulas in ano, right? So once you have diagnosed in your patients with fistula in ano, the management depends upon what type of the fistula that you have. Is it the type 1 variety or the type 2 variety, or do you have the type 3 or a type 4 variety? For a type 1 or type 2 variety, you can go ahead with fistulotomy to open up the tract. You can also go ahead with fistulectomy. So you have the fistulotomy, you can go ahead with fistulectomy. Also, you can go ahead with laser. You have the laser fistula tract closure. Or you can also go ahead with fibrin glue injection. These are the other options for closing the fistulous tract. Rishabh, you're talking about the tags, no? They're called a sentinel pile. Sentinel piles are a feature of fissure in ano, not fistula in ano. Okay? Sentinel pile alag hai, pile alag hai. Pile is called as hemorrhoids. Sentinel pile is called as skin tags. Skin tags are seen in fissure in ano. So then you have type 3 and type 4 ke liye, you will go ahead with set-on. It's a set-on placement, which is usually a cutting set-on. So the basic concept of this cutting sit-on is, if you have, this is the perianal skin that you have, and there is the opening of the tractus here, opening of the tractus here, and the tract is going like this. Now because it is going through the internal anal sphincter, it is going through the external anal sphincter. Now if I go and try to operate, I will cause more damage to these sphincters. So see, if the sphincter's mechanism is lost, the patient will have incontinence. I cannot have a patient develop an incontinence. So what we do is, we take a thread, right? It's like a cutting thread that you have. I will insert the thread into the tract and I will pull it out from here, right? So this thread has traveled through inside. Now what I'm going to do is, I'm going to tie these two threads, right? Now imagine it this way. Okay. So what you're going to do is, now I've tied this thread and I'll continue to tighten it. Now as I tighten, because it's a cutting thread, now as I tighten, it will cut through, and then it will open up the tract, but lower end will continue to fibrose. In that way you prevent the incontinence, and this is what you do in the context of cutting sit-on. Okay. So this is all that you should know in terms of fistula in ano, right? So we finished our last question on the GIT part 2, and that is our fistula in ano as well, right? So all the important questions from our exam is being covered. Do have a look at it, this video. You will have, I'll be uploading the notes also, but then a quick recap on the entire concepts as well as the whole topic list that we have covered is important. Okay. So that is it for today in terms of our Farre GIT part 2. We have another series at night 9 o'clock, and that time we'll be talking about the trauma and the neurosurgery part. I mean, that's a neurosurgery trauma part that is left behind. We'll cover that as well, right? Until then, thank you so much for joining. I'll resume back at night tonight at 9 o'clock. Okay. So see you again at 9 o'clock. Thank you. Bye.